would like to present on stage Dr. Tasbia Akhtar Lamia, lecturer of Department of Anatomy. Present her presentation about coronary artery disease.
Assalamu alaikum, respected Principal Sir, Vice Principal Madam, all department heads of first phase, respected Sir Madams, my colleagues and students, I am Dr. Tasbia Lamia, lecturer of Department of Anatomy, welcoming you all on today's presentation on anatomy of heart and coronary artery disease, which is one of the core topics of integrated teaching program. Let's enjoy a 3D view of heart, how it works in our body. Heart is a hydromuscular organ of a conical or pyramidal form with a base, apex, and a series of surface and borders. Heart is occupied in the middle mediastinum between the lung and pleura and enclosed by the pericardium. Heart is consists of 4 chambers, 2 atria and 2 ventricles. Right and left atria receive blood and right and left ventricle pump the blood out of the heart. Heart is consist of 3 layers, epicardium, myocardium and endocardium. It is from the outward to inward. Epicardium is the outermost protective layer of heart. The epicardium is composed of mesothelium, a cell type that covers and protects most of the internal organs of the body as well as fat and connective tissue. Myocardium is the middle muscular layer of cardiac wall. It is located in between the endocardium and the epicardial layer. And endocardium is the innermost layer of the heart. It lines the inner surface of the heart chambers, including the heart valves. Epicardium and myocardium is supplied by the coronary arteries, and endocardium gets nutrition from the lumen gland. Heart is supplied by actually the right and left coronary artery. The right coronary artery arises from the anterior aortic sinus of the ascending aorta, and the left coronary artery, the larger branch of 2 coronaries that arises from the left posterior aortic sinus of the ascending aorta. The coronary arteries have some branches, like right coronary artery give branches of posterior interventricular artery, marginal artery. Posterior interventricular artery supplies the ventricular valves, and the marginal artery gives supply to the valves of right atrium and right ventricle. Left coronary artery give 2 branches, circumflex artery and anterior interventricular artery. The circumflex artery supplies the wall of left atrium and left ventricle, and anterior interventricular artery supplies the ventricular valve. And after the venous blood is actually draining the cardiac veins and then coronary sinus and finally to the right atrium. The coronary artery has some variations like there are some right dominance, left dominance and balanced dominance. Let's discuss about the dominance. Right dominance, we found this on 90% of population and it is actually defined by the posterior interventricular artery whenever it is the branch of right coronary artery. And in case of left dominance, only 10% of people have left dominance. The posterior interventricular artery when arises from the circumflex branch of the left coronary artery, it is called left dominance. And balanced dominance or co-dominance, it actually represents the posterior interventricular artery when it comes from both coronary arteries. And there is some clinical importance of this dominance. The right or balanced dominance, when a block in right coronary artery at least spares part 2/3 of the septum and left ventricle. In case of left dominance, a block in left coronary artery affects the entire left ventricle and interventricular septum. The coronary artery has some peculiarities like coronary arteries are vasodilated during the sympathetic nerve supply. It is the only artery which gets filled up during diastole of the heart, and coronary arteries are functional end artery. That means they have no precapillary anastomosis but have a capillary level anastomosis. But in spite of having the capillary level anastomosis, this anastomosis cannot establish sufficient collateral circulation. And sometimes the left coronary artery arises from the pulmonary trunk or anterior aortic sinus. If the coronary artery lies behind the pulmonary trunk, it may be compressed aorta and pulmonary trunk during severe exercise and it can cause sudden cardiac death. Collateral circulation, cardiac anastomosis. There are some anastomosis present in the myocardium. The types of anastomosis are as follows: arteriovenous anastomosis, interarterial, arteriosinusoidal anastomosis, sinoluminal anastomosis, arterioluminal anastomosis, luminosinusoidal anastomosis. And the sites of anastomosis are as follows. First, in the incisor epicis cordis, cracks of the heart, anterior atrial wall, Kugel's artery, anterior surface of right ventricle, posterior surface of left ventricle, interarterial septum, and interventricular septum. These are all the site of anastomosis of coronary arteries. And in case of coronary artery disease, prognosis is better in old age than in the young because anastomosis of coronary arteries multiply with age. Now we will know why coronary circulation is important. As coronary arteries supply blood to heart muscles like myocardium, which is rich in oxygen, any coronary artery disorder or disease can have serious implications by reducing the flow of oxygen and nutrients to the heart muscle. And this can lead to a heart attack and possibly death. Now we will know about the conducting system of heart, which is very important. The conducting system actually includes the sinoatrial node, atrioventricular node, bundle of His, left branch and left anterior branch, left posterior branch, right bundle branch, and further node Purkinje fibers. And this conducting system is supplied by right coronary artery, except the left branch of the atrioventricular bundle that is supplied by the left coronary artery. Now we come to the topic about the coronary artery disease, which is one of the core topics of today's content. Coronary artery disease is a common heart disease where coronary arteries struggle to send enough blood, oxygen and nutrients to the heart muscle due to cholesterol deposit in the arteries. Blood clot coronary artery spasm, coronary artery disease, or atherosclerosis are the most common causes for coronary artery disease, and there are some types of coronary artery disease. There are as follows: atherosclerosis, acute coronary syndrome, angina pectoris, and myocardial infarction or MI. Risk factors for coronary artery disease are divided into two parts, like non-modifiable risk factor and modifiable risk factor. Modifiable risk factors are ethnicity, age, gender, family history. And in case of modifiable risk factor, they are abdominal, obesity, high blood pressure, diabetes mellitus, high cholesterol, physiological factors, and smoking. The rest part will be continued by Dr. Rakibul Islam, lecturer of biochemistry. Thank you. Thank you all. There was a mistake, sorry for that. I apologize for that. Dr. Tasnim Taranum Apu, lecturer of physiology, will continue the rest part about the coronary arteries. Thank you.
Thank you, Dr. Lamia. Honorable Principal Sir, all the departmental heads, respected faculty members, and my beloved students. Assalamu alaikum and a very good morning to all of you. I am Dr. Tasnim Taranum, lecturer from the Department of Physiology. Already we have known the basic concept of coronary artery disease. The most important investigation we prescribe for coronary artery disease is about electrocardiogram or ECG. I will now share some valuable knowledge regarding electrocardiogram. At the end of the session, we will be able to learn the definition of ECG, to identify the different leads of ECG and their location, to able to identify waves and intervals of a normal ECG, to calculate heart rate from an ECG paper, and to know about the ECG changes in ischemic disease. Now, what is electrocardiogram or ECG? It is the graphical representation of the electrical activity of heart during cardiac muscle measured from the surface of the body by placing suitable electrodes on the skin and with the help of an electrocardiogram. Now comes the question, what is electrocardiogram? It is a galvanometer with 6 leg leads and 6 chest leads, which records the electrical activity of the heart on a graph paper with divisions. The indications of electrocardiogram. By an ECG, we can measure the heart rate and we can assess some clinical conditions like cardiac arrhythmias, chamber hypertrophy, conduction abnormalities, myocardial ischemia and infarction, electrolyte disturbances, and some drug toxicities. This is a diagram showing a normal ECG. A normal ECG consists of 3 waves: P wave, QRS complex, and T wave. QRS complex often has 3 separate waves: U wave, R wave, and S wave. Now comes the first wave, P wave. It is the most positive and first wave in electrocardiogram. This wave produced due to atrial depolarization. The clinical significance of P wave is to guide to the functional activity of atria. The abnormalities of P wave. In case of atrial fibrillation, P wave will be absent. In atrial hypertrophy, P wave will be large and may be notched. In case of nodal rhythm, the direction will be reversed. Now comes the second wave, QRS complex. It represents the depolarization of ventricular musculature and the abnormalities of QRS complex. It can be prolonged in case of interventricular conduction delay, right bundle branch block or left bundle branch block, and in case of severe hyperkalemia. QRS complex can be tall due to hypertrophy of one or both ventricles, left ventricular failure and right ventricular failure. In case of infants, QRS complex is absent in congenital patency of septum, and Q wave will be prominent in case of old infarction. Now comes the third wave, T wave. It represents ventricular repolarization and the abnormalities of T wave. T wave will be inverted in case of myocardial ischemia or infarction and in case of left bundle branch block. T wave will be low or flattened in hypokalemia and pericardial effusion. Tall tended T wave will be at hyperkalemia. Now comes the intervals of ECG. The most important interval is PR interval. It is the interval from the onset of P wave to the onset of QRS complex. It measures the conduction time of impulse from the SA node to the ventricles. The PR interval will be prolonged in case of anteroventricular conduction block. If the conduction time from anterior to ventricle is more than 0.4 seconds, then it is considered to be complete heart block. QT interval. It is the time from the start of the QRS complex to the end of the T wave. This interval represents ventricular depolarization and repolarization. QT interval will be prolonged in ischemia, ventricular conduction defect, hypocalcemia, and short QT interval caused due to hypercalcemia. ST segment. It is the period between the end of the QRS complex and the beginning of T wave. It represents ventricular repolarization. ST segment can be elevated due to myocardial infarction and pericarditis. Depressed ST segment indicates cardiac ischemia. RR interval. It is the interval of time between two successive R waves. It is the most important interval to determine the heart rate and rhythm of the heartbeat. Now, how we can calculate heart rate from an ECG paper? If cardiac rhythm is regular and we calculate the large squares, heart rate will be is equal to 300 divided by number of large squares in between two successive R or P waves. And if we calculate the small squares, the heart rate will be 1500 divided by number of small squares in between two successive R or P waves. Now comes the most important topic, that is ECG leads. Lead may be defined as the combination of two wires and their electrodes to make a complete circuit between the body and electrocardiogram. Our standard ECG has 12 leads. ECG leads in broad heading can be classified by two types: chest leads or precordial leads and limb leads. In ECG, we have 6 chest leads, V1 to V6, and this diagram is showing all the positions of the chest leads. Now about the limb leads. Limb leads are of two types: unipolar leads and bipolar lead or augmented leads. Bipolar leads are of 3 types: lead 1, 2, and 3, and unipolar leads are also 3 types: AVR, AVL, and AVF. This diagram is showing all the positions of the bipolar limb leads. Now about the augmented limb leads. When two of the limb leads were connected to the negative terminal of the electrocardiograph, while the third limb lead is connected to the positive terminal, it will be known as augmented limb leads. And the figure is showing the augmented limb leads. When the positive terminal is on the right arm, the lead is known as AVR lead. When on the left arm, it is known as AVL lead. And when on the left leg, it is known as AVF lead. For the placement of the ECG leads, we have to know the Enthoven's triangle first. It is the triangular area created around the heart by the three limb leads is known as Enthoven's triangle. And the Enthoven's law, it states that if the ECG is recorded simultaneously with three limb leads, the sum of potentials recorded in lead 1 and 3 will be equal to the potential of the lead 2. These are all about my ECG presentation, and I want to give a last message from my ECG presentation, and that is, no beauty shines brighter than a healthy heart. When we take care of our hearts as part of our self-care routines, we reduce our risk of heart diseases. Everyone should do a regular ECG every 6 months after the age of 35 to 40 years to reduce the heart diseases. Thank you all. Now I am inviting Dr. Rakibul Islam from the Department of Physiology for our biochemistry for our next presentation. Thank you.
Assalamu alaikum. Myself, Dr. Muhammad Rakibul Islam, lecturer of biochemistry. I would like to give thanks to Dr. Tasnim Tarannamapu for inviting me to share my knowledge of cardiac markers and their associations with cardiac diseases, that is coronary artery diseases. And I would like to share that I am very close to the end of these topics. Now, I will start from the investigations that has already been discussed a little bit. For diagnosis of coronary artery diseases, we do some common investigations, though several complex procedures require specialized facilities. But we do these procedures in clinical outpatient department or bedside test. So already ECG has been described, and I will go for cardiac markers. So we have to know the cardiac markers. What is cardiac markers? These are intracellular enzymes or structural proteins released to the blood following cardiac muscle damage due to ischemia. That is, common example is myocardial infarction or other SRs, and shows a serial change in plasma concentration with initial rise and followed by a fall. Clinical uses of these cardiac markers. Diagnostic use for diagnosis of myocardial ischemia, that is MI. Prognostic use, assess the prognosis of myocardial ischemia. Risk stratification of the diseases involving myocardial ischemia. What are the types of cardiac markers? Structural cardiac muscle proteins, there's a troponin, and in troponin there are common troponin I and troponin T, and myoglobins. And enzymes, creatinine kinase, lactate dehydrogenase, and aspartate aminotransferase. So we will see the kinetic behavior of cardiac markers following cardiac muscle damage or following myocardial infarction. First one is myoglobin, which is initially rises within 2 to 4 hours of myocardial infarction and goes to the peak level within 8 to 12 hours, and that is declined to normal by 24 hours. And troponin I, that is rising within 2 to 4 hours of myocardial infarction or myocardial ischemia and goes to the peak by 12 to 24 hours, and it returns to normal within 5 to 10 days. Creatinine kinase, MB, 4 to 6 hours of myocardial ischemia and goes to peak to the 12 hours and decline to normal 2 to 3 days. Aspartate aminotransferase, that is goes to the initial rising 6 to 8 hours of myocardial infarction and peak at 24 to 48 hours and goes to the normal by 4th day. And last one is tachycardia dizziness. It goes initial rising within 8 to 12 hours of myocardial infarction and goes to the peak 48 to 72 hours and decline to normal 7th day onward. So I have already mentioned that I am very close to the end of the topics. No more today because it is the last part designated for our beloved first phase students. Thank you all for your patience hearing, and I also like to give thanks to Dr. Naik for his kind help regarding making all these topics more comfortable. Thank you.
Dr. Nazrian Lamia, Dr. Taslim Tarnum, Dr. Rakibul Islam for your nice presentation. Now it's time to see a traditional drama performed by my beloved students of EWMC 20 batch. My students, welcome on the stage.
মেয়েটাকে যে স্কুলে নিয়ে যেতে হবে সেই ধ্যান আছে?
ঠিক মতো ঘুমাইতে হবে না, সারা জীবন খালি আমার ঘুমটাই দেখলাম।
হ্যাঁ হ্যাঁ, তোমার কাজের মধ্যে তো ওই দুই খাই দাই আর শুই। যাও মেয়েটাকে স্কুলে নিয়ে যাও।
তাড়াতাড়ি চলো আপু, দেরি হয়ে যাচ্ছে।
কি মিয়া কই যাও?
এই তো বাসায় যাই, ঘুমাবো কে বাসায়?
হ্যাঁ আমার সাথে ব্যায়াম করো, সকাল হয়েছে ঘুরি তো বাড়িছে অনেক বেশি।
বুঝো কি বুড়ি হলো পুরুষের সৌন্দর্য।
না আমি ঘুরি তোমার বোঝাইবো, আসো ব্যায়াম করো।
তোমার চোখে তুমি তেল দাও।
বুঝবা বুঝবা।
এই দেখো আবার এসে ঘুমায় গেছে। ঝুমুর আব্বা ওঠো, গরম গরম রুটি বানাইছি, খাবে আসো, তোমার তো আবার অফিস যাওয়া লাগবে।
এই রুটি আমি খাই না।
তো তোমার জন্য কেন প্রতিদিন পোলাও কোরমা রান্না করে রাখবো? 14 গোষ্ঠীর সবার ডায়াবেটিস আর হাই প্রেসার, উনি আসছে রুটি খাবে না। যাও যাও
সকাল সকাল বিড়ি খেলে পেট ভরে যায়।
যাও যাও অফিসে যাও, আসার সময় বাজার নিয়ে এসো।
দাও দাও ব্যাগটা দাও।
আসেন ভাই আসেন, তাজা তাজা সবজি নিয়ে যান, কি নেবেন নেন, অনেক তাজা সবজি আজকেই তুলছি।
কি আছে তোমার কাছে?
মূলা আছে, ফুলকপি আছে, গাজর আছে, টমেটো আছে, বাঁধাকপি আছে, কি নেবেন নেন।
মুলার জুস বানায় আর তুমি খেয়ে ফেলো।
আসেন ভাই আসেন, গরম গরম কাচ্চি তেহরি বিরিয়ানি খুবই মজা, একবার খাবেন বারবার খাবেন।
বিরিয়ানি কত টাকা?
মাত্র 100 টাকা। আমি করোনারি আর্টারি,
আমি কোলেস্টেরল,
আমি হার্ট ব্লক।
বুকে ব্যথা উঠতেছে রে, আজকে বিড়িটা বেশি করছে। যা একটু পানি খাই। সাথে স্যার বাসায় যাই। জোর মাতো তাড়াতাড়ি আসো, বুক ব্যথা শুরু হয়েছে। জোর মাতো
কি হয়েছে? কি হয়েছে তোমার?
এই যে বুকে ব্যথা হচ্ছে।
কি হয়েছে তোমার?
বুক
বুকে ব্যথা
ব্যথা
করতেছে।
এখানে
আম্মু আম্মু দেখে যাও, আপু যেন কেমন করছে।
কি হয়েছে মা? কি হয়েছে তোমার? তোর আব্বার কি হয়েছে তোমার? তুমি এমন করতেছো কেন? হ্যাঁ তুই এখানে যা, তোর হাঁচা চাচা ডেকে নিয়ে আয়।
চাচা চাচা
হচ্ছে?
ইসি বলবে হ্যাঁ
মনে তো হাসপাতালে নিয়ে যাওয়া লাগবে।
আস্তে আস্তে বসে
কি সমস্যা আপনার?
বুকে ব্যথা শুরু হয়েছে স্যার।
ঠিক কোথায় ব্যথা অনুভব হচ্ছে?
এই তো বুকের মাঝখানে।
ব্যথাটা কি ছড়াচ্ছে?
জি স্যার।
এর আগে কখনো এরকম ব্যথা অনুভব করেছেন?
এই তো 2 মাস ধরে এরকম ব্যথা হয় মাঝে মধ্যে।
কি করতেন তখন? কোনো মেডিসিন নিতেন?
এই তো গ্যাস্ট্রিকের ওষুধ খেতাম ব্যথা হলে।
কি বিপদ?
স্যার পেশেন্টের ব্লাড প্রেশার তো হাই 170/.
আপনার পরিবারে কারো কি উচ্চ রক্তচাপ, ডায়াবেটিস, হৃদরোগ আছে?
জি স্যার, ওনার মায়েরই ছিল।
কি মনে হয় তোমাদের?
স্যার যেহেতু চেস্ট পেন, চেস্ট টাইটনেস আছে, আমার মনে হচ্ছে স্যার coronary artery disease হতে পারে।
স্যার আমারও তাই মনে হচ্ছে যে যেমন অ্যাঞ্জাইনা হতে পারে।
কোনো পরীক্ষা নিরীক্ষা ছাড়া আমরা কি করোনারি আর্টারি ডিজিজ বলতে পারি? এর জন্য কিছু টেস্ট করতে হবে না? এর জন্য আমরা কি টেস্ট করতে পারি?
স্যার আমরা প্রথমে ইসিজি করতে পারি।
সিবিসিও করা যেতে পারে।
এগুলো আর ইকো, প্রোকোনিনাই, চেস্ট এক্সরে। ঠিক আছে, আমি কিছু টেস্ট দিচ্ছি, টেস্টগুলো করিয়ে রিপোর্ট নিয়ে আমার কাছে আবার আসবেন। আর আমি কিছু ইমিডিয়েট মেডিসিন দিচ্ছি ব্যথা কমার জন্য। সাথে আপনাকে কিছু অ্যাডভাইস ফলো করতে হবে। বেশি করে টাটকা ফলমূল এবং শাকসবজি খেতে হবে, অধিক তেল চর্বি ও মশলাযুক্ত খাবার এড়িয়ে চলতে হবে, সময় মতো ঘুমাতে হবে, ধূমপান থেকে বিরত থাকতে হবে এবং সুস্থ হওয়ার পর দৈনিক অন্ততপক্ষে 30 মিনিট করে হাঁটতে হবে। আশা করি এগুলো মেনে চলতে পারবেন।
ইনশাআল্লাহ ডক্টর চেষ্টা করব আজকে থেকে বিড়ি খাওয়া বন্ধ।
ঠিক আছে, টেস্টগুলো করে নিন।
ডাক্তার সাহেব, উনি কি বাঁচবেন?
জি, চিন্তার কোনো কারণ নেই, উনি সুস্থ হয়ে যাবেন। আমাদের বাংলাদেশের প্রেক্ষাপটে আমরা প্রায়শই হৃদরোগজনিত ব্যথাকে অ্যাসিডিটি বা গ্যাস্ট্রিকের ব্যথা মনে করে অবহেলা করে থাকি। কিন্তু আজকের এই ব্যথায়, আজকের এই অবহেলায় একসময় পরিণত হতে পারে করোনারি আর্টারি ডিজিজ বা হৃদরোগে। তাই এখনই সময় সচেতন হওয়ার। আমরা সবাই সচেতন হই, সময় মতো ডক্টরের শরণাপন্ন হই, সুস্থ সবল দেহ করি এবং হৃদরোগ প্রতিরোধ করি। কারণ আমরা জানি প্রিভেনশন ইজ বেটার দ্যান কিউর। প্রতিকারের চেয়ে প্রতিরোধ উত্তম।
Start taking care of your heart before it falls apart.
Beat the heart disease to feel the healthy beat.
Live smart for a healthy heart. Do your part, care for your heart.
Do your best, keep the smile and hit the track. Health and heart go hand in hand.
Fully healthy heart, nothing goes off.